Hello, hi, this is Dr. Scot Hutchison. Thanks for tuning in for this episode of Hutchison's Huddle, which is about polycystic ovary syndrome. Because it is Polycystic Syndrome Awareness Month, if you didn't know that, for the United States. So sorry we had a little bit of trouble getting our streaming going, but anyway, let's spend about the next half hour or so discussing polycystic ovary syndrome and how to fix it. So polycystic ovary syndrome affects somewhere between about 6 and 20% of the population. I think it's probably a reasonable estimate is probably around 15% and growing. Certainly when I was a fellow, polycystic ovary syndrome patients were fairly rare. We would see a few a week in a large division that had 6 fellows always and several faculty members. This week alone, I have seen 6 new patients with polycystic ovary syndrome, and the week isn't over yet. So there is quite a bit of polycystic ovary syndrome out there. Now, most diseases have been described years and years and years ago. Hundreds of years ago. People just couldn't do much about them. Polycystic ovary syndrome has been described, the first time it was described was in 1935. So relative newcomer to the world of diseases, and certainly would qualify as one of those diseases of civilization. And the first paper written about it was in Journal of American Medical Association, and it was 2 Chicago gynecologists named Stein and Leventhal. And Dr. Stein and Leventhal had noticed that there were that they'd been seeing a number of women who had irregular menstrual periods, had a lot of body hair growth, and then when they did pelvic exams, they could feel their ovaries. Their ovaries were large. They were worried they had ovarian tumors that were producing testosterone because those had been described, forever ago. And so they took those women to the operating room. They opened up the abdomen. They would take out to look at the ovary. The ovary was huge, so they would take a scalpel and they would cut into it and they would wedge out a large portion of the ovary looking for a tumor. And lo and behold, they would not find any tumors, but they found all these little, what they called cysts, scattered around the periphery of the ovary. So those cysts are just follicles that have been recruited abnormally. So the criteria for polycystic ovary syndrome are really, it depends on whether you use the National Institutes of Health or the Rotterdam criteria, but most of us kind of feel like it's that you should have maybe 2 of the 3 or 3 of the 3 for polycystic appearing ovaries, irregular periods or trouble with ovulation, and evidence of hyperandrogenism or higher male hormone production. So there's, the big question is, why did we get to having a lot of polycystic ovary syndrome cases now rather than hundreds of years ago? And the answer is really pretty cool, and that is that there are a number of genes, and so far there are about 43 genes that are strongly associated with polycystic ovary syndrome. And they are these mutations of different things for different proteins, like the insulin receptor, like the luteinizing hormone receptor, like how you initiate steroid hormone production. And those genes, in a roundabout way, probably help people survive in terms of starvation. And then there are some genes that help them maintain their egg reserve longer, so they actually have more eggs than other people. Well, that's all great right now if you're living 400 years ago and there's not a lot of food around and there may be starvation and you want to be able to survive with less food, or you want to be able to survive like a 10-year famine and then be able to actually have a baby on the other end of that. So that, those genes were really helpful then. But then some other things happened that made them not so helpful. And one of the things was that the carbohydrate intake started to go up really dramatically, especially after World War II, especially sugars. And that can cause some developmental programming or imprinting to kind of go awry. So if you feed pregnant mammals a lot of carbohydrate, you will start messing up the way they can read their DNA. So the DNA may get altered by having different methyl groups placed on the DNA strands, which then can really interfere with the way that the DNA transcriptase molecules bind to the DNA strands and read the DNA. So that was one thing. And we know that, for example, even if you starve a pregnant mammal, you will imprint her offspring to be much more likely to be resistant to insulin, much more likely to be a calorie sparer, much more likely to become heavy in the future. Then also a lot of the processed foods, and again, you got to give some of these food scientists a break, because they were, one of the big problems of public health has been clean water, safe food. We kind of take it for granted that you can go to a restaurant and you don't have to worry about getting sick. So food scientists had really been working at ways to preserve food really well. And some of these preservatives, it turns out, like propionic acid and trehalose and all of the artificial sugars and even the naturally occurring sugars like xylitol and maltitol, these things are really bad for gut bacteria, and they then kill off our good gut bacteria, which help us to be much more insulin sensitive. Then, so there's three things, you got these genes going, you got this imprinting phenomenon, you got damage to the good gut bacteria. Then on top of it, people stop eating fermented foods. So it used to be, to get at least through a winter, you were eating sour. If you were living in a cold area, cold climate, cold Asia, cold Europe, you were eating fermented foods every day. Things like sauerkraut and kimchi that had lots and lots of lactobacilli to repopulate your lactobacilli you may lose. So that went away. And then things got automated with regard to transportation. So it used to be you had to walk everywhere, or you had to ride a horse, or both. Recently we were up in the mountains, and we were talking with this rancher, and that their going to school was 7 miles each way. A lot of it they could do. Sometimes they could do it on horses. A lot of the time they were walking it. So if you can imagine, how many kids walk 14 miles to go to school a day? I mean, it's just nobody. So that lack of exercise also then makes people more insulin resistant, which tends to drive up their insulin levels. And that in turn makes the ovary make more male hormone, which will stall out ovulation. So that's the mess we're in. And the weird thing about it is that these effects can be what's called transgenerational. So they're getting worse over time. So if your grandmother ate a lot of high carbohydrate food during pregnancy, or if she was starved, you're toast. You're going to have a harder time, having a good metabolism. There was a study that came out last year that showed that if you're a Dutch man living today and your grandfather was in his great-grandmother during the Dutch famine winter of 1944-45, which is when the Nazis were trying to starve out the Dutch and everybody was starving on that side, that now you, as this Dutch dude living today, are much more likely to be obese and type 2 diabetic than your counterparts who didn't have that going on. So how do we fix it? So historically, when clomiphene first came out, clomiphene is an anti-estrogen receptor drug that was first produced by the William Merrill Company. And literally this is the 51st birthday for clomiphene. And if you talk to people who had anything to do with that drug, and my dad worked for that company a long time ago, it was just miraculous. So people wouldn't, these people, they had thought they were all sterile and that they were never going to have kids. And then you would give them this medicine that they would take for 5 days, and like most of them got pregnant. It was amazing. It was just miraculous. So but now we know, I mean, people are so much more insulin resistant that you can't just like throw them Clomid and then they'll just ovulate. So it's kind of legendary to hear patients will say like, yeah, my mom had polycystic ovary syndrome. They gave her Clomid. She said she took it. She got pregnant on the first cycle. She had me, then she had to take it a couple of times to have my brother, but it was really easy for her. Well, now the number of patients who you can just throw Clomid at and they get pregnant right away is really low. If they do, that's great, but a lot of the times as they get older and they get more insulin resistant, they're not going to ovulate as well, and they're going to need more doing, okay? So there's kind of in reproductive endocrinology, there have been different schools of thought with this. I mean, some people like to go straight with just doing the, give them the Clomid first and see what happens. I'm kind of in the other camp where it's kind of like, I kind of view polycystic ovary syndrome like trying to put together an IKEA sofa. I don't know if you guys have had to do that, but it's kind of a hassle. And if they, in that little like wordless piece of paper that gives you the instructions on how to put it together, if they say, get out your flathead screwdriver, get out your Allen wrench, get out your hammer, get out the Phillips head or whatever, get them out. Don't sit there and go, I think I can do it with just the Allen wrench. It's going to, maybe you could. It's going to take you forever. So the way I like to look at polycystic ovary syndrome is, let's just try to get it done as fast as we can. So what I think that involves is approach it from like every angle that we could make a difference. So rather than just going right to Clomid, what I like to do is to kind of start with the basic underpinnings of the disorder. So if high insulin levels are causing some of the trouble, let's go ahead and dry that up. Let's go to a Mediterranean type diet. Very little sugar, less starchy fruit, maybe some berries. Try to go as organic as humanly possible. Eat a lot of fatty fish because it has the omega-3 fatty acids that are really important for brain development for babies. And it's very good for helping lower the risk of preeclampsia down the road during the pregnancy. And it is just good nutrition. And it doesn't cause inflammation. Take the red meats out of the picture. Take the things that create a lot of inflammation, like the sugars, like breakfast cereals, processed foods, out of the picture. So pretty much what I like people to have for food is like eggs with kimchi in the morning, or sauerkraut, because you're going to get those good gut bacteria. You're going to give them a safe place in those vegetables to hide through the stomach so that they get into the intestine and do you some good, and maybe make your bacterial flora better. Then for lunch, like poultry, nuts, vegetables, leafy greens, putting more olive oil and butter on the vegetables so that you get more fat in your diet so you're not as hungry. So that you're not going to be breaking weak, eating, junk food that you shouldn't be eating. Again, the fish can be really good for the lunches. I encourage people to eat that fatty fish like sardines or salmon, shellfish, 5 to 7 times a week. You really don't have to worry about mercury. Institute of Medicine settled that a long period of time ago. And then for dinner, kind of the same thing. And then if you want a snack, eat organic popcorn with butter or olive oil on it, but don't eat like Flamin' Hot Cheetos and these highly processed things that kill off our good gut bacteria. And then we get depressed, and then we just want to eat more sugar and junk food. I mean, stay away from that stuff. Okay, so that's the nutrition part of things. As far as the activity, yeah, we should have some exercise in there. Now, nobody's going to be able to walk 14 miles a day. We all have busy lives. We all are slaves to our computers at work. We need to be able to shorten that up. So what I like people to do is like the 7-minute workout, like 5 times a week. It's a free download for your phone, and it puts you through 30-second intervals for 7 minutes. I mean, who can't do that? I mean, that'll make you breathe hard. That counts for your exercise. Then there's a medication called metformin, and there's a question here, something about metformin. The question is, how does metformin work? Metformin is this old biguanide type 2 diabetes medicine. And pretty much my feeling with metformin is it just punishes you if you eat carbs. So there are people, my son was telling me that there's all these Silicon Valley billionaires now who want to live forever, so they're taking metformin, and it really is probably is a life extender, and it's probably really because if they sit there and their wife goes, "Hey, honey, would you like a Dove bar?" Yeah, if they eat it, they'll get diarrhea. So that's really kind of what metformin does for polycystic ovary syndrome. But I do like it for that purpose. It does seem to help with ovulation. It's so that's a tool that we can use as well. Metformin now, we're telling people to stop once they get pregnant or maybe after first trimester because it appears to be associated with childhood obesity or an increased risk of that. However, you got to say, hey, look, all these polycystic ovary syndrome patients are developmentally modified themselves, or their programming is off, they're imprinted. They're going to have higher risk of having kids with childhood obesity. Duh, So anyway, but metformin traditionally has been thought to be very, very safe in pregnancy. The next tool that I like to use is a supplement called inositol. And inositol is a sugar-like molecule that instead of being broken apart and used as fuel like glucose, it's an insulin signaler. So it helps the insulin carry across its signal so that you don't have to make as much of it. And it actually may be more important than the metformin for induction of ovulation in polycystic ovary syndrome patients. But every time I try to look at the literature on that, it's a little sketchy because there's really no incentive to do. Maybe somebody will write a good grant and get a good NIH grant going to like compare like inositol versus metformin in a really rigorous way. So since inositol is really well tolerated, I've only had a couple of patients who said that it tasted weird to them. To me, when I've tried it, it tastes kind of sweet. But that, taken 2 grams a day in about 4 ounces of water, really appears to help with insulin sensitizing and can be very helpful as well. So, and then time is also our friend. If you're on this sort of program where you're modifying your nutrition, you're taking out the junk food, you're getting the good bacteria into your gut with the kimchi and sauerkraut, you're doing your exercise, you're taking the metformin, taking the inositol. A lot of people now, even really very insulin resistant, very polycystic looking ovaries, a lot of those are going to ovulate and do really well. However, we don't make people wait. I mean, most patients who I see for polycystic ovary syndrome have been trying to get pregnant for 1.5 years to 2 years. So they're anxious about it and they want to move on and get on to the fun part. So I will usually put them on that plan for about 2 months because 2 to 3 months is about what it takes to get a whole new cohort of follicles growing. So those follicles that have been treated better, it's just like with sperm. If guys are smoking or they're smoking pot or they're drinking a lot, God, it takes about 3 months to really get into a whole new cohort of sperm that are actually going to function well. So I like to go for at least 2 months and then use medication like letrozole or clomiphene. So clomiphene, like we were talking about, is an estrogen antagonist. It binds to the insulin receptors. It does not allow for signal transduction to go very well for estrogen. So the brain starts to make the pituitary gland make more follicle-stimulating hormone to push the ovaries to make follicles. Letrozole works in a little bit different way. It blocks an enzyme that's converting weak male hormone to estrogen, and that in turn kind of tricks the brain into thinking there's not a lot of estrogen around, and so, we got to make more estrogen. So and it's sort of the same thing happens. You ramp up FSH pulsatility, and then you're able to recruit follicles better. Both of them have an increased risk of multiple gestation. I personally tend to see, and I think the literature supports this, that you get fewer follicles with letrozole than you get with the clomiphene, but both are okay and seem to have about the same effectiveness, letrozole probably being a little more effective in the studies that have been done. Clomiphene has a pretty rough side effect profile, especially at higher doses. Because of that estrogen signal transduction interference, headaches, hot flushes, irritability are legendary. For people with pre-existing depression, it'll tend to make that worse. That part really bothers me, because a lot of people, I would even say the majority of polycystic ovary syndrome patients have mild depression. There are some of these gene clusters that have been identified with polycystic ovary syndrome also are associated with depression and with other metabolic problems like abnormal lipids, and gaining weight, and even male pattern baldness. So a lot of these things are kind of tied together, and if you have somebody who's already depressed, you don't want to make them more depressed. It's like I saw a patient, well, I've seen many patients where you get them on the clomiphene and they get so dang depressed that then they're just treating themselves, either trying to eat a lot of sugar, eat a lot of starch, or drink, or smoke pot, none of which is really accomplishing our goal of trying to be healthy and have a baby. So I'm not a really big fan of clomiphene at this point. I do have patients who come back after 2-3 years, when we were using it more of it in the past, and they got pregnant with it and they want to use it again, and they didn't have a lot of trouble with it, and in which case I'm fine with it. But I do like letrozole better. So usual dose for the letrozole is a couple of pills or 5 milligrams a day for 5 days, but we can go longer than that, and we can certainly go at higher doses than that, up to 10 milligrams to kind of get things done. But I usually will start with that 5 milligrams for 5 days, and then you look with ultrasound after about 10 to 12 days of from starting, and you kind of see if it's starting to work. If it's not, I typically will have them come back, a few days later, maybe, depending on how big the follicles are, about 5 to 7 days later. But I'll tell them, hey, get on the exercise even a little bit more. So instead of doing one 7-minute workout for 5 days a week, maybe do 2 of them and do them every day, or go walk some stairs, up and down, some staircases for 15 minutes a day or 30 minutes a day, breathing hard, so that you can actually try to get that, and then really tighten up those carbs. And that will usually do the trick. If it doesn't, what I usually will do is put people on oral contraceptive pills for about 42 days in a row, and then hit them again with the letrozole, usually 5 milligrams for 10 days. That gets about 85% to 90% to ovulate then with that. And if the husband's had good semen parameters and if fallopian tubes are open, then most of the time people are going to get pregnant with that approach within a few cycles. Certainly once you get pregnant, you want to stay with that dietary plan. You got to think to yourself, hey, I am not like a normal person. I have a metabolism that is different. I do not want to eat junk food. I do not want to sit there drinking juice and eating donuts, things that are going to drive my insulin levels up, because that really is probably very detrimental to the offspring. So anyway, so that's kind of the basic management plan. There are rare outliers who will not ovulate with any of that, in which case we have to go to injectable fertility drug. But the watchword with that is you start with a really low dose, and you slowly work up over time, and you look frequently with ultrasound to make sure that you don't overshoot the mark. Once you step into that injectable fertility drug arena, you are now incurring a risk of not just twins, but of triplets and quadruplets and beyond. So we need to really take those. We need to be very judicious with how we super ovulate polycystic ovary syndrome patients. So a lot of patients are out there who have endometriosis or male factor or unexplained, and we're trying to super ovulate them, and they'll get pregnant and they'll have one baby or whatever, and then they'll tell their friends, hey, I use these giant doses of whatever these medicines are. Hey, polycystic ovary syndrome patients with husbands who have normal semen parameters, that's a totally different arena. Do not try to super ovulate them. The goal is to just ovulate, just to be like a normal person. So anyway, I think we've covered that. So there's a question about testosterone in polycystic ovary syndrome. So testosterone production is higher in most patients with polycystic ovary syndrome, but not all. And it's not much higher even for that. So like normal for an ovulatory woman is, who's like having ovulatory 28-day cycles, if you check her day 2 to 3 testosterone, it's usually around 20, 25 or less. Sometimes you'll see it, down in the basement, 13. Big deal. It's not important. Most polycystic ovary syndrome patients are going to be in the 30s and above. A fair amount of them. I saw somebody last week who had a testosterone of 105. I mean, this is really in the no good range, where it's doing something bad with egg quality. It's doing something bad with hair, and we'll talk about that in a second. But that excess testosterone really may be driven by, there's a whole other set of gene variants of mutations that will make people have higher testosterone production. So we want to lower that. One of the ways we can lower that is getting people to ovulate then will make the liver make more steroid hormone binding globulin. It'll bind to that testosterone and it'll kind of secrete it so that it can't cause biologic effects like bad lipids. Also, the testosterone production, it does have spillover effects. For guys, it's what makes us stronger. It makes our bones a little stronger. But the downside to it is it makes you hairy, and it thins out the hair on the top of your head if you're kind of in that situation. So, I mean, some guys have like that awesome, like Tom Cruise has super awesome hair. There's, Brad Pitt, we were watching his new movie last night, super awesome hair, and he's like just a little younger than me. Every day I look in the mirror, my pate gets a little shinier. So we don't want our female patients to have to deal with that. So we want to get ahead of those higher testosterones as soon as we can. So in adolescence, preferably, like I always tell my residents, if they're starting to complain about abnormal hair growth on their body or, on their chin, on their, if they're seeing their hair on their head thinning out, intervene now. With regard to that, if you've got an adolescent who's not trying to get pregnant, I mean, the obvious thing to do is to put them on birth control pills and then get them on the whole standard polycystic ovary syndrome plan, maybe minus the metformin. But really good nutrition, which is hard to do with adolescents, but really good nutrition, exercise, plenty of sleep. And that reminds me, sleep deprivation causes insulin resistance. There was a really elegant study that was through University of Colorado that was published a few months ago that showed that when they took these college volunteers and they put them in a testing center, which is kind of like a prison, because they really wanted to make sure they couldn't cheat with this sleep deprivation study. When they woke them up after 5 hours and then let them eat whatever they wanted and drew their blood every day, within 5 days, they were all pre-diabetic. Then they started to gain weight. So, sleep deprivation is horrible for people. It's the World Health Organization labeled it as a probable carcinogen. So don't mess with it. Get your sleep. And that goes for both genders. I mean, make sure you've got really good sleep hygiene. These handheld devices are great. Stuff like this social media is great to a point. But, turn your phone on to nighttime settings at about, at 7 o'clock. No screen time. If you don't have to do this for work, don't do it. I mean, stop and deconnect at about 7 p.m. at the latest, and no more screen time. And make sure that with regard to your sleep, that your sleep area is how you want it to be. So whatever temperature that is. And then if you don't fall asleep within 15 minutes, 10-15 minutes, you get up out of bed and you go read something boring. If you wake up and you can't go back to sleep after you empty your bladder, again, get out of bed, go read something boring. You will live, but you need to train yourself to fall asleep and stay asleep in bed. You cannot train yourself to be awake and looking at things and trying to learn things or think about your friends or about all that other stuff that kind of creeps into there. You need to train yourself to when you get into bed, you lay down, you fall asleep instantly. And most people can do that, and I can attest to that. So how does PCOS go after you have a baby? So in other words, should you stay on the metformin afterwards? And I think that's really it's up to everybody. I mean, I've had, going back, gosh, almost, 20 years now, when we first started to use metformin, lots of times I would say to people, they'd call in for a refill of it, and I'd be like, well, you had a baby already, you don't need to be on it again. And they'd be like, Dr. Hutchison, I got my waist back after taking that drug. It made me eat right. And so I want to be on that drug. I think it's fine if you do, if you want to keep taking it. We don't really know the long-term ramifications of long-term metformin use. They seem pretty safe. Certainly if you need IV contrast and you've already got a little bit of kidney failure, like if you're in a car accident, it might not be so pretty for your remaining renal function. But I think in the big picture, you could probably stay on it for the long term. I would probably stay on the inositol, or at least eat a lot of high inositol foods like beans every single day. And then the exercise and the yearly diabetes screens, and then the yearly laboratory checks to make sure that you're not going to drift into type 2 diabetes and heart disease and have a higher risk of stroke. And same thing goes for blood pressure checks. You really need to have those done. Most polycystic ovary syndrome patients kind of have borderline hypertension, and a lot of them, I would say probably 15-20%, need to be on an antihypertensive. So get a good blood pressure cuff at home. Talking with my pharmacist who sells a lot of those at Target, he was saying, though the store brands don't tend to work as well, get the good Omron one, because people rarely bring those back. But I would be good about checking your own blood pressure every so often with that. And the goal really is, in most of the literature now, is to keep your long-term blood pressure at about 120 or less for the top number, the systolic, and about 80 or less for the bottom number. So there was also a question about diagnosis. Why can it take so long to be diagnosed? Honestly, I think it's just a failure of medical education, and the fact that we all do different stuff, and we all have different things that as clinicians that we're looking for. And so it's legendary. It's already been several times this week with these 6 new polycystic ovary syndrome patients that I've seen, that they'll say stuff like, well, when my periods did start at age 16, which was really late compared to all my other peers, they were really light, but I was told, hey, that's good. And then they got really irregular, and then the doctor said, hey, it's nice, you don't have to worry about having as many periods. Well, no, that's not okay. So yeah, anybody who's having irregular periods, even right out of the gate in adolescence, should be evaluated. They don't even need to really have pelvic exams at that particular point. They could probably just get started on birth control pills. So, anyway, but if they're sexually active, that's a really good thing to do as well. But yeah, I think the main thing is just be suspicious, and as patients and as healthcare consumers, we just need to ask more questions. And if things don't seem to really be, matching up the way that you think they are, then you get another opinion. Anyway, so I'm sorry that we're not able to stream the way we normally do, because normally I can see people's questions and I can't see any of that right now. But please, if you have other questions, I think there's a way you can submit those, and then I can address them on another one of these down the road. So to summarize, if there's suspicion that you got polycystic ovary syndrome, get a lot of sleep, eat healthy food, get some exercise, get in with the doctor and talk about starting metformin and inositol, and then be judicious with the use of the fertility medicines, especially the injectable fertility drugs, especially IVF. We've got a corporate practice here in town that that is a little, I think they're focused mostly on the money. It's apparently owned by a venture capital company. And I've seen several patients where they have, the patient comes in, gets first diagnosed with polycystic ovary syndrome, and instead of going down this path of, hey, let's get you normal, they go to, hey, let's do IVF. And even the paperwork says, we discussed that IVF is the best way for achieving pregnancy. Well, yeah, for them maybe, but honestly, I really think that, and IVF is a great tool, but we know that if you don't treat people with the whole plan of getting them to try to ovulate on their own and getting better egg quality, you're going to get a ton of eggs and you're going to get poor quality embryos. And then who knows what other kinds of bad stuff you've done to those embryos as far as imprinting. Plus, IVF is a great tool, but if you can spend your first 5 or 6 days inside your mother, I think it's probably safer. So we have a lot of IVF babies out there that are totally normal, but in the big picture, all of this imprinting or developmental programming stuff, I really think if you can get pregnant yourself, let's do that, and then if you can't, you can maybe move on to IVF. But anyway, so if you have other questions, give a ring. Before I forget, so hair, a lot of people will say, well, how do I get rid of this hair once I got it? Whole point is, let's try to prevent you from getting it in the first place. But if you got it, you got to destroy it. Most of the time, if you've got fair skin and dark hair, that's really amenable to laser. You can wax repetitively over time, as long as you're not recruiting new hair follicles. As long as you put the brakes on new hair follicle recruitment, you can get rid of those hair follicles by eventually, you wax enough or you laser enough, you'll destroy the dermal papilla that's generating the hair. Also, with regard to hair on your head, a lot of polycystic ovary syndrome patients will panic when they deliver because during the pregnancy they started growing really, really thick hair, and then when that placenta comes out and all the steroid hormone production just falls through the basement, the way that the hairs on the head are recruited for growth changes, and immediately 2/3 of the hair follicles will fall. 2/3 of the hair shafts will fall out. And so people will think they're going to go bald. You won't. It's just that instead of having 1/3 growing hairs, 1/3 resting hairs, and 1/3 empty hair follicles, you've now shifted it. You shifted it to 2/3 growing hairs, and now you've shifted it to 2/3 empty follicles, which is very disturbing. And but it typically will turn back around. Anyway, if you have other questions down the road, give us a ring. My shout outs to Karina Bakame, who is helping us with this tonight, and to my other collaborators, Doctors Celia Valenzuela, Aaron Sperry, Kevin Murphy, Alina Lackenpaul. Feel free to look back on our Facebook Live sessions with them on different things like endometriosis and hypothalamic dysfunction, because those are really good for patient education. And then if you've been one of our patients or in the past or are now, feel free to come to the family fiesta that we're having at Reed Park on October the 13th from 10 a.m. to 2 p.m. You can register through the Facebook page, or you can register through 2019, this is all one word, rhcfamilyfiesta.eventbrite.com. And Eventbrite is EVENTBRITE. So 2019 rhcfamilyfiesta.eventbrite.com. And we'll look forward to seeing you there, and have a great night, and have a happy fall.